What about fluid therapy in setting of hyponatremia? In case of hyponatremia, we divide the patient into three categories. First of all, into hyperosmolar, isoosmolar, and hyperosmolar. And then after that, you have to look for the hydration status and the volume. So I will talk here about somebody who is hyponatremic and have hypovolemia. So for hyponatremia associated with dehydration, you have to avoid all hypotonic solution because the patient already hyponatremic. Isotonic saline is the IV fluid of choice for such patient. 3% saline, usually we restrict it to severe hyponatremia and mainly for somebody who is having CNS symptoms in form of seizure or coma or altered level of consciousness. All the time we said that the rate of correction for sodium, it should not exceed 12 millimole per 24 hour or 18 millimole over 48 hours, and this is very important to prevent osmotic demyelination syndrome. What about fluid therapy in hypernatremia? So it is the opposite here. It is very important to calculate the water deficit. Because the hyponatremia, we have two parts of hypernatremia. The first part, either there is excess of salt, and this is very rarely we see it, except if somebody who is drowned in the seawater and then he drinks significant amount of the seawater. But most of the hypernatremia are related to less free water. Like, let us say that dehydration or water deficits. That's why it's very important to calculate the water deficit. You have to consider also the ongoing fluid loss. The free water, it is the fluid of choice and it should be given PO or if somebody in the ICU by the NG tube. If the patient cannot take PO or the patient doesn't have nasogastric tube, you can give it by the IV route as D5 water. Again, the aim of hypernatremia is not to correct the sodium very quickly, rather than that to correct it over 24 hours.